Good evening, everybody, and welcome to today's episode of Marvelous Medicine. Happy Pongal, part of the country you're in. It may seem odd that we are discussing something like this on a festive day, but I sincerely feel that just like we should live well, we should die well as well, and that's very important as our population in India is getting older. I'm really grateful that all of you chose to spend your evening on a festive day with me. Without much further ado, I'll just quickly introduce all our panelists. We are extremely fortunate to have Dr. Rajkumar Mani, who's the Director, Clinical Services and Chairman, Critical Care and Pulmonology at Yashoda Hospital, Ghaziabad. He's been the past President of the Indian Society of Critical Care Medicine and the past editor of the Indian Journal of Critical Care Medicine. He's been instrumental in drafting the end of life care guidelines and for extracorporeal lung assistance. The Supreme Court legal procedure for withdrawal or withholding care was extremely complex, especially for clinicians. He was actively involved in simplifying it so that the Ministry of Health guidelines on ICU admissions and discharge, withdrawal, and withholding life support could be done, and ordinary clinicians in the intensive care could actually start practicing it. As is evident, his areas of interest are end-of-life care, ethics and laws for treatment limitation, respiratory support, and healthcare administration. He has over 100 publications to his credit. Thank you so much, Mani sir, for immediately accepting my invitation, and thank you so much, Somnath, for putting me in touch, though we hadn't been in touch with him for a long time. We're equally happy to have Justice Kannan Krishnamurthy, who's the Director, Madhyastham, Mediation and Arbitration Practice. He was formerly a judge of the Punjab and Haryana High Court at Chandigarh. He has served as the Chairman, Railway Claims Tribunal, New Delhi. He's a prolific legal author known for his authoritative textbooks and especially intersection of law and medicine, which includes a textbook of medical jurisprudence and toxicology and medicine and law, exploring areas of intersection. He also writes regularly in the lay press, extremely informative articles, and he's always got a different take on what is going on in the country. Justice Kannan Krishnamurthy is not new to our Marvelous Medicine audience. And one of the things he said in one of our meetings that it's okay for a lawyer not to know medicine, but a doctor should know the law. And not knowing the law is not an excuse when something goes wrong. So again, thank you so much, Kannan sir, for sparing your time today. We also have Dr. Rahul Pandit, a distinguished leader in the field of critical care. He's the chair of Critical Care and Emergency Medical Services at the Department of Critical Care Medicine at Sir H.N. Reliance Foundation Hospital. Dr. Rahul Pandit, this is MBBS and MD in anesthesiology from Mumbai, after which he went to Australia and received his fellowship at the College of Intensive Care Medicine of Australia and New Zealand. He's a pioneer in critical care echocardiography in India and is an expert in the management of brain death and organ donation. Dr. Rahul Pandit used to be in the Fortis group of hospitals when I was also part of the Fortis group. And he was one of the first who came up with simple guidelines to about PPE and how to don and doff. And his lectures and videos were extremely, informative, and it made our life very easy at the beginning of COVID when we were all, struggling to cope with it. Next, we have Dr. Vasant Karthikeyan, who's a medical director, Gericare, and consultant geriatrician and elder care systems and care consortium at Chennai. He did his MBBS from KAPV Medical College, Trichy, and MD Geriatrics from Madras Medical College. He's currently leading clinical governance, care quality, and service governance across hospitals, home care, and assisted living. And I thought a geriatrician would be an ideal person to join the discussion today because we are going to be talking about living will and end of life care. We are extremely happy to have Dr. Rajam Iyer, and I'm thankful to Dr. Mallika Thiruvadanam for putting me in touch with Dr. Rajam. At very short notice, she agreed to join today's panel, so thank you so much. Dr. Rajam has done MD, DNB, and MRCP and is a national fellow of the palliative medicine, and she also has a diploma in palliative medicine. She has done a master's in respiratory medicine and has done many years of clinical work in both India and international setting. She is currently a trustee with Pallium India Trivandrum, and again, I thought palliative care physician would bring a lot of inputs to today's discussion. Last but not the least, we have Dr. Ganesh Ram, who has been kind enough to take time off on a working day. He works in the United Kingdom, but he immediately agreed. And thank you, Dr. Akila, for putting me in touch with Dr. Ganesh Ram. We know that our systems of living will and advanced medical directive are not very mature in India, but from what I understand, in the United Kingdom and in the National Health Services, these systems have been in place for a while, and I thought he could help us to understand how they go about doing it, and how we can catch up with them sometime soon. Dr. Ganeshram is a consultant physician and geriatrician with interest in stroke at Glenclyde Hospital. I'm sorry, I'm unable to pronounce the name of his hospital, but I thank you once again, Ganesh Ram. Though you have just got back from a holiday, you immediately agreed to join us, and we eagerly look forward to your input. And of course, Dr. Puneet Dhar, the moderator for today, needs no introduction. He's one of the very key persons in our Marvelous Medicine group. He's a GI surgeon and with special interest in transplant and in medical ethics and medical humanities, other than being a busy surgeon. So over to you, Puneet. I think I've taken too much of your time.
Is that okay?
Yes.
Yeah, I think it's, congratulations to Marvelous Medicine for thinking up this extremely important topic and something which we all need in the country. I mean, Marvelous Medicine has always marveled at teaching medicine in ways which are not taught in textbooks and classrooms. And I think this is one such session, and I think we can see a record number of beginning before the actual session has started. And I think a lot of MBBS students and all have also joined, which was the original intent of Vidya and Patta. So I warmly welcome all the panelists today for this important topic. And I think a lot of movies have been, Whose Life Is It Anyway? A lot of Hindi movies, the famous Aruna Shanbag case, have made us think, but we really don't know the nitty gritty. And before we go to the nuts and bolts, I think to understand living wills properly, we must first establish the legal foundation. And there's no one better than Justice Krishnamurthy to turn to for this. He's written a fantastic article in the Hindu. I'll put that in the chat box, the link to that. I think we must all read that. It's small but completely emphasizing why we need passive, even though we can't go for active euthanasia at the moment. So I think we turn to you, sir, and could you help us understand the current legal status of the living wills in India following the various Supreme Court landmark judgments, and what are the key legal protections it provides both for the physician, the family, and the patient? What are the essential legal requirements for a living will to be valid and enforceable in India?
Thank you, Dr. Puneet Dhar, and thanks to all of you. Normally, what happens is in a court setting, you hear arguments from parties, and then when everything is all done and dusted, you have the judge saying something. Now, here you are inviting me as a first speaker. So, therefore, that's a new privilege of what I have not enjoyed before. Thank you very much for this. Again, this starts, you want to know the legal underpinning. What happens is probably it stems from a very simple clause in the Constitution. Article 21 talks about no person shall be deprived of his life and personal liberty except in due process and except in accordance with procedure laid down by law. So all it says is right to life exists. There must be a procedure which is established. Therefore, otherwise, without it, you can't even hang a person even for a capital punishment, which can be done. That is a procedure which has to be laid down. That's all the law requires. But over a period of time, we have made expansive understanding to Article 21, right to environment, right to decent living, right to die with dignity. That comes there. So therefore, when we are talking about a living will, an advanced directive, it is a kind of an oxymoron. When we talk about will, it's invariably the last will and testament before a man dies. And there is nothing else. And that the will speaks from the grave of the person, as it were. So it can't take effect when the man is living. But then there is one exception for this again, thanks to an expression which was founded by an American author who wrote in 1969, as early as that. He talked about a right to life with dignity, right to die with dignity, and called it a living will. So living will came there in 1969, and 1976 California made the law that at the time California law was a natural death act. So we get a kind of a hint. If it's not natural death, you prolong death by unnatural ways, isn't that? So that's the way 1976 the legislation came. And then from there on, we never had any legislative activity in this field till one journalist took up a case of a nurse. That's history. Many of us will know Aruna Shanbag case was there, where Justice Kaju, who wrote, he said, now this is filling up a vacuum of where the Indian law does not lay down very clear guidelines. And therefore, till the law happens through a legislative activity, our judgment will stand in place. But then that was not, they looked to the court as the only way. They must come and then take an approval. That's how it was. That was not the right thing to happen. And therefore, there was a 5-member bench which happened with the Common Causes versus Union of India. Common Cause, incidentally, a prominent name, what we know, Arun's father was is a social worker, and he started this Common Causes. It's a trust. So the 5-member bench gave a kind of guideline, and therefore it talked about passive euthanasia and said, no, do not want active euthanasia. The expression again is familiar to all of us. I'm not going to take you to that. But what are these key provisions of what it talks about? It recognizes something which is very, very fundamental: autonomy. Whenever we talk about living will or advance directive, we are talking about the right of a person to give an advance directive in order that somebody who is treating the person acts on the directive when he's not in a position to give any more direction. So therefore, we are assuming that a person is given a directive which is advanced in character to the present state of his ill health, which is not good enough for him to give any directives. That is the first one. And what is the second thing which happens on account of this? There is immunity to doctors. Anything of what that person does to withdraw the life support does not require to be probed further to know whether the doctor has been negligent, because this is again an interesting thing. I'm so surprised and happy that we have brought a full spectrum of whatever would be relevant. We have an expert to speak about that. I'm sure the ethical considerations, how do you balance interest between the patient's right to die if he chooses to die and the doctor's ethical boundary? How do you balance? These are interesting issues. I'm not going to be talking about it. I'm greater experts are there, therefore I'll leave it to that person. I'm merely talking about the legal components. One which we said is the patient autonomy, which is important. Second is the legal immunity to doctors, or what it provides if a doctor acts on the directive. And the third one is a relief to the family. It's a big thing that they do not have a surrogate decision to be taken. What should we do? Should we withdraw life support or not? These are issues which ever confront a family. This big dilemma for many of them. It's an emotional issue. Did I take care of my parent? Did I withdraw something earlier? Could he have survived? All these things. There are always stories that we hear, don't we? That a person rose from the grave. So you took him to the burial guard, and then this person got up. All these kind of things happen now and then, and therefore there are the issues like this. What are the legal requirements we are talking about? I was saying we are talking about a will. The most essential thing is we are talking about a person who is competent to execute a will. Therefore, we are talking about competence arises in Indian condition to persons who are 18 years and above. Therefore, advanced directive is possible to be given only by a person who has completed 18 years. A person who is a minor can't do. A person who is imbecile or a congenital idiot who doesn't understand, he can't do or she can't do. So therefore, we are talking about a competent, legally competent person who is therefore 18 years of age, a person who understands what he's doing and is doing it in a free sense, is not compelled to be doing. This is again a very serious problem. The compulsions of what could exist. Countries where you have good support systems, like in UK or USA or Canada, and many countries where healthcare is free, poverty is never an issue. To say, no, I can't live anymore, I can't suffer, I will be indebted more, and therefore I'll opt for death. Those kind of things could be difficult. Therefore, a person could be directing or instructing the doctor, I can't suffer this pain anymore. The pain may not be really physical. It could be mental, or what he is going to leave for the family. Huge indebtedness is an issue for medical care. So therefore, we don't have that. And therefore, when we are restricting it to passive euthanasia, withdrawing life support, we are talking about that is a free thing of what is taking place. And the content, it must clearly state that treatment should be withdrawn and specify that it can be revoked at any time. Now, revocation, a component of revocation is a very important thing. So these are something which I have also written about. What is the time limit which you should give? When do you revoke? Is it a fickle-minded person that we are talking about? Not necessarily so. When we are talking about life, it's so precious. It doesn't happen to a person every now and then. It just happens once and that person dies. You don't know what is going to happen. Philosophical questions of what happens after death is always going to be raging for ever so many centuries. So the important thing is, it must clearly state, today there is going to be a judgment. In fact, I was thinking that I'll have something interesting to share with you. A Punjabi a person on Rana, he fell off from the 4th floor. And he is in the year 2012, and he's in a state of coma. Now, at the time, he didn't give any advance directive. So what do we do? When they were talking about living will, advance directive, dignity in death, somewhere the court was thinking, are we talking about pulling out from the ventilator or taking away food also? Is that also? What is the component of that? That dignity in death of what we are talking about, the withdrawal of life support. Life support, should it be through a machine-induced support of what we are talking about, breathing, or is it something more, of food, nutrition, all that, would that come within that? The real content, the component of what is withdrawing of the support was never too clear, and that is likely to be coming through Pardiwala and K.V. Vishwanathan, sensitive judges. I wouldn't doubt about their capabilities at all. So therefore, I would expect a new facet to come through a pronouncement of what didn't come today. They have reserved it for judgment, and reserved, it is anybody's guess when it's going to be. But normally we can understand in Supreme Court about a month's time is fairly a good enough time for us to be expecting a judgment. And one Ms. Bhatti, who has supported the government and has given, I had an occasion to look at the written arguments. She has talked about those kind of things of what is necessary, food and nutrition. Would that go into withdrawal support is what she has talked about. There shall be a named proxy. It is the person must appoint a named person to do an act, to communicate to the person, to say that this is the directive. He does not want in a case of a comatose state, he does not, or she does not want any more resuscitative measures. That's something which you can be doing. The next thing is witnessing this. Is that such a big thing? It's a big thing. Any will gets valid only if it is attested by, we use an expression called attestation. I'm sure all of you get to be knowing that notary public attestation is something many of the persons who are there, doctors who have worked in government hospitals, attestation is an expression which we all understand. Attestation is by two persons who shall be again competent person. They can't be a minor attesting. Previously, the requirement in law was that attestation must be before a magistrate, a judicial magistrate. Magistrate, to get it to meet a magistrate is a very difficult thing even for a high court judge. So therefore, talk about any person going to a magistrate and asking for an attestation. The first thing which you'll say is, I don't know, I don't have time. The Fedar or the Wali will not let you in to see the magistrate. So came Joseph Bench, which was constituted about 4 or 5 years later, took into account the actual difficulties which is involved. And then they said the attestation need not be there by the executive magistrate. They've taken it away. But then there are still some very serious issues, like this document is required to be a copy to be given to be to the municipality or a corporate body. You ask any corporate authority whether they have received any one single will, living will. I'm not too sure. And it happened, from my experience in a talk to doctors in PGMR some years back, post my retirement after I came away from Chandigarh, I was asking, is there anyone who has seen a living will? Not one doctor put up his hand. So therefore, I'm not surprised that what we are talking about is something still not very common. And those few persons who has come to me to see that they would take a will, a living will, an advanced directive, I prepared it for them. And I've had later occasion to see, did you have any occasion to send it to the municipality or corporation? They said, no, we have not. So therefore, that is the legal requirement. I think your question came, and I'm sure I've not exceeded the time limit. I was trying to keep to the basics of what was the legal requirement, what does it make it to make it work, and why did it come about, and what is the legal background for such an exercise, and where this expression came. Just one more advanced directive also comes because Dr. Vidya was asking whether a note that she had prepared was all right. The only thing is advanced directive came, and also the Donation of Organs Act, when the transplantation of organs also made provision for this advanced directive, where how the person's body organ is to be used. But then that's a very different thing from this, because there can be the patient's relative could have a veto. They may say, no, we don't want anything done, and we don't want this body to be given. All that can happen there. But it's a dead body by that time, and therefore doctors probably don't make a big fuss about it. But here is something where this is to be acted upon at the time when the person is alive, and therefore the importance that if somebody is going to veto it, that will be quite a problem. When doctors may still veto, could be an exercise which is an ethical question, which I'm sure is somebody talking about that, and I will be interested in knowing what the ethical considerations as they conceive of. So this to me is a beginning statement. I suppose I've laid out the turf reasonably well and clear for you, unlike the usual propensities of prolixity that we engage as judges, saying things that everyone does not understand. I've attempted to be as plain and simple as possible. Thank you. That's for my opening statement.
No, thank you so much, sir. That was crystal clear. I think you really clarified the legal landscape. So much done, and so much still needs to be done. Now, having a legal right is one thing, but implementing it raises profound ethical questions. Dr. Mani, this is where your expertise becomes crucial. From an ethical standpoint, how do living wills balance the sort of patient autonomy with the doctor's duty to preserve life? So, we don't teach that properly in medical school. What ethical dilemmas do healthcare providers actually commonly face when interpreting advanced directives?
I think there would be more dilemmas if there were no advance will in place, because preservation of life is a very narrow way to look at doctors' duties of care. It has expanded a lot, with the advent of modern medicine. There is a duty of care to listen to the patient, to honor the autonomy. It's not just a legal right, it's a moral duty for the doctor to respect autonomy and to preserve dignity in death. That's part of our job, because not everybody can survive. And a good proportion do die in spite of all the modern medicine interventions. And the modern medicine interventions become a burden in more ways than one, not only physical, but also emotional and financial. It wrecks financial status of many families. In fact, for a good 40% of families find themselves economically compromised with one ICU admission. So all this, it's a human issue. It's not just a rights issue alone. That it is the duty of care to balance the four principles of ethics. respect to autonomy, to act always for the benefit of the patient. That's what the best interests argument. And to balance it against non-maleficence, that we don't want to harm the patient in any way. If there is no help with interventions, it harms. Okay, that has to be taken note of. It harms by prolonging the dying process, prolonging pain, violating the integrity, bodily integrity, and also compromising the values, not respecting the values of the patient. You see, and then there is the justice of it. We should act fairly, not disproportionately to what is needed by the patient. When the patient is dying, just piling on interventions like ventilation and dialysis is not the mission or the goal of medicine at all. In the dying patient, we have to give the care appropriate to the dying process. That is what to ensure the dignity. And for that, we need to know the values and wishes of the patient. Now, the patient can't express directly. Then we depend on the family and the surrogates to represent the patient. Or more directly, if there is an advanced will. Now, advanced will, even where it is very prevalent, is only in the minority of patients. The vast majority, the doctor has to balance through accurate prognostication and what is the personality of the patient as reflected through the family's conversation would want or would value in these circumstances. But if there is an advance will document, it's a great help. It is not the final menu card. Even then, we have to balance what the patient is saying with our duties of beneficence and non-maleficence. If the best interests suggest that the patient's wishes be completely followed, so we have to match that with the best interest also. If there is something patient hadn't envisaged, at the time of executing the advance will, wouldn't have known that in the scenario that he will be in, it could be salvaged. Okay, there's a high degree of salvageability. Then obviously one can override the advance will, which goes against any intervention, but that has to be properly reasoned and documented. It is not an arbitrary, random decision. Okay, so the dilemma is not for preservation of life. The dilemma is in marrying to the clinical condition all the four pillars of ethics: autonomy, beneficence, non-maleficence, and justice. That is where the doctor's skill comes. The skill is not just in doing a procedure or giving an intervention or giving a drug. It is in judging the appropriateness of what we do and the inappropriateness of what is going on in case there's a lot of disproportionate treatment going on, and to take a valid, balanced decision between the four pillars of it. They are equally important. All of them are equally important. The rights of the patient, which is reflected in autonomy, should be combined with the duties of care, as I mentioned, beneficence, non-maleficence, and justice, fairness. So the medical standards, okay, the benchmarks, are already, they have made these standards. Since the 1990s, these standards are, and they are being supported or underpinned by law and legislation in various countries. And I'm glad that our country has also caught up, although slowly. Okay, what was established 50 years ago in US and UK, we are trying to come to grips with it now. We are very quick to adopt any new technology, okay, new intervention. I mean, the gap is only 5 years. But in the ethical, moral field, we have not kept abreast at all. We have allowed it to drift, and we are still asking those questions which have been already been asked and answered adequately even before the 90s. I must say, for judging appropriateness of care, which is normal medical care, which is part of normal doctor's duty, we have complicated it by making very, very difficult procedures in law. Because appropriateness of care for a patient is a very everyday decision making. If you walk ICU, 1/3 of the patients will need these decisions, to be honest. So greater or lesser degree. It's not just withdrawal of ventilator. Life support can be through artificial feeding, which is the case in point with Harish Rana. And it should not be looked at as active euthanasia. Why? Patient is vegetative, will not feel any hunger, will not feel anything really. And all those physical discomfort can be controlled with palliative care, with appropriate medicines. We don't have to just feed meaninglessly, pointlessly, okay, and keep somebody alive like Aruna Schonbach for 40 years. That is not my medical standards dictate. Medical standards say that you must cut your cloth according to the patient. Okay, care should be appropriate.
That's so important, particularly in our country. The confused mass of private, public, self-paying, third-party payments. So I think thank you for giving us the ethical compass in these issues. But let's move on from principle to practice. Dr. Pandit, you work in one of the most high-stakes environments in medicine, the ICU. How does this play out when decision must be made urgently? Can you share how advanced directives actually impact decision making during critical moments? What happens when the family wishes conflict with the patient's documented advanced directives? Dr. Mani referred to one such case. I have a patient right now who in the ICU. I agreed with him when he said do not intubate. He had a early colon cancer, so we 88-year-old, we said go ahead with surgery. He did pretty well abdomen wise, but he said do not intubate. So I was in complete agreement. But then he had a pneumonia. In between I thought maybe we should try a bronchoscopy, and they said we won't do a bronch unless they give us permission to intubate. So again, exactly highlighting what he said. So a lot of problems there. So how do you address this, Dr. Pandit?
Thank you very much, sir, and good evening, everyone. So, by the virtue of being a critical care specialist, one part which is taught to us very well is to try and preserve life, because very often we come into a situation where we do not have enough information on the background. And this is when you are seeing the patient for the first time, or the patient has been referred to you for the first time, and there is no clarity of what is happening on the background, like your patient, sir, which you mentioned, 88-year-old with colon cancer. If this was a met call, for example, or code blue in my hospital, the first response from the ICU team would be to do whatever could be done to preserve life. However, as the time goes by and you have more information coming in, which could be a few minutes to an hour or so, or maybe sometimes days as well, you come to know that the patient's wishes, or as you talk to the family, if the patient has not expressed the wishes explicitly in writing, but they have been in the part of the conversation which they have had with the family, that this is not what they wanted. They would have wanted a quality of life, or if the quality of life was not going to be preserved with the medical interventions, they would not want to prolong the misery, or they would not want to be in a vegetative state, to be put simply. In that cases, I think the decision making becomes easier, where the family agrees and the patient's wishes are very reasonably documented or very well known. And you as a doctor and the medical team find that this is going to be a futile care. So the dilemma starts happening, sir, when you feel that this is not a futile care. That's where majority of the doctors actually struggle, because for them, pneumonia is a treatable condition. It's a reversible problem. So why don't we treat pneumonia while the colon cancer can wait? Just taking your case a little bit further into the depth. The second problem occurs when there is a conflict between the patient's wishes and the family's wishes, which is the biggest one. And at that point, sir, most of us as doctors take a back seat, because if I was to actually take a expression from Marathi, nobody wants to climb the stairs of Justice Krishnamurthy's court or the police stations, because that's where it comes to. You are sort of threatened with a medical legal case. The hospitals have their own way of interpreting the law, and they take a back seat and they all become very defensive. So you are left there standing to sort of defend for yourself and say that no, the decision for the patient is right. So coming up to a point that if the patient's wishes have been clearly written as an advance directive, I would have no hesitation standing there and defending the whole cause that I need to do the thing right for the patient. And one of the things which Justice Krishnamurti said that we need to give it to the advance directive needs to be submitted to the municipal corporation or a local body. Sir, there is now a DigiLocker, and I've been promoting that. There's an Aadhaar card on the DigiLocker where you can actually upload your documents, and that becomes your own documents as long as they share the Aadhaar card or the login documents with somebody that they've been actually put up. This can be accessed because municipal corporation, as you said, sir, I don't think there is even a process to accept such a document. If I go today to Bombay Municipal Corporation and ask the commissioner, forget about anybody else, commissioner, that where can I submit this living will, they will have to create a process today. They don't have that process as of now. Now coming back to your question, sir. So most of the times I would take up a assent and an agreement of the family before we think of withdrawal of life sustaining therapy or end of life care decision. That's where my second trouble becomes. While the Honorable Supreme Court has been extremely kind and clear in the process of laying down the things which we have to do for actual withdrawal of life sustaining therapy, which is your primary board, secondary board, and then inform the joint magistrate, the magistrate, the first class magistrate. The clause in the secondary board, which says that one of the doctors should be actually appointed by the district appropriate authority, it could be from the same hospital, has not been adopted by most of the states, including Mumbai. I'm struggling still to actually have that. And I don't know if I may be wrong, but under the Supreme Court's process of withdrawal of life-sustaining therapy, I haven't heard that one withdrawal of life-sustaining therapy has been done using that process. People are withdrawing care, and ethically we are right to do that. But under that process, whether the primary board form, secondary board form, and a withdrawal of life-sustaining therapy has happened, I don't know a case. And Mani sir, you may correct me if I'm wrong, but I don't remember, or I've not heard of a case in the last 3 years. The judgment came in 2023. We are in 2026 January now, and I haven't heard a single case which has utilized that judgment's power to actually do it in the legal and the nice way, where 6 doctors are involved. So I think we are still in a very, very gray zone, sir, as far as different aspects are concerned. Only when you have a clarity with the patient's wishes, which are written, and a family agrees to it, the process is easy. If a doctor, and doctor may not be necessarily the intensivist like me and Dr. Mani, there are other doctors who may feel that this is a reversible problem, leave alone the problem with which the patient has got admitted with, because that's a treatable problem. Let's give 2 days of dialysis. Let's do 5 days of antibiotics and see what happens. And this is where we forget that the basic problem that the patient actually has got a condition which is irreversible and is not likely to make. And then the difficulty of actually withdrawing. So that's my, I hope I've answered the questions.
Yes, thanks so much. I think that is a very
Terminal 1 jana hai bhaiya.
Dr. Pandit has shown us the critical care perspective of every moment counts. Dr. Iyer, in palliative care, the timeline may be different, but the stakes are equally profound. How do advanced directives shape the journey towards a peaceful end of life? In your palliative care practice, how do advanced directives help patients maintain the dignity and control at the end of life? What's the ideal time to have these conversations about advanced directives? The moment they're referred to you or a little later? What Dr. Iyer, please, Dr. Rajam Iyer.
Thank you so much. Thank you for this opportunity. So like all the other panelists have said, when the patient is actually referred to me is when the specialist, especially the pulmonologist or the intensivist, realizes that the patient is at the end of the road. So what I'm trying to tell you, Rahul did say about patients being acutely admitted to ICU. In a country where a lot of the non-communicable diseases, we have a burden of COPD, chronic obstructive lung disease, interstitial lung disease, dementia, Parkinson's, any chronic illness and conditions, including cancer, the specialist is aware of the trajectory of that particular illness. And that is where the role of palliative care and advanced medical directive is very, very crucial, because you know how a dementia behaves. One specialist knows how a COPD behaves. And that is the time to integrate palliative care as early as possible, to have these difficult dialogues with the patient who still continues to have a mental capacity and the family to tell them what may lie for them in future. So it's very important to integrate as early as possible. As you will agree with me, it's better to learn to swim when the sea is calm and not in a storm. And more importantly, the earlier the integration, everybody is probably getting more time to listen to what we have in store. So especially if you have an elderly frail at 90, you can't talk to him at that stage. He has been turning 90 for those many years. So in a chronic condition, integrating palliative care as early as possible, having these conversations and documenting with advanced medical directive is actually a win-win for the patient, win-win for the intensivist, for the hospital resources, the family, and overall, like Dr. Mani said, we are actually minimizing and mitigating suffering, which is one of the biggest roles of physicians. I mean, we are not here to fight over death. The point is we need to realize that death is inevitable, but we need to avoid bad deaths. And that can be done by giving the patient his autonomy, his right, his body, his decision, and therefore giving him time to write his medical directive so that in the time of emergency, everything is crystal clear about how he would like to be treated and therefore give him what he wanted. So, early integration of palliative care. I think we should at least start with chronic conditions. Yes, the dilemmas can exist in the intensive care if the patient has just walked in, but we have a whole lot of non communicable diseases that Indians suffer with, which are completely addressed, and we really treat them like a first time emergency when we know the background, we know the lung function, we know the HRCT, or we know the MRI of the brain, and we know that Parkinson's, dementia are all incurable conditions. So it's very, very crucial for us to include training of AMD and living wills, so that as practicing clinicians, we pick up these points and cues at appropriate time in the trajectory of the patient's illness.
No, thank you so much. I think Dr. Iyer has beautifully illustrated the role of the advanced directives in the end of life care. Now, many of these, conversations happen in geriatric practice. It reminds me of that book, Being Mortal by Atul Gawande, where he's, balanced these two parts of it. Dr. Vasant, you work with elderly patients in India daily. What's your experience? How do you approach discussing living wills with elderly patients and their families in the Indian context? What cultural or familial factors in India influence how seniors think about advanced medical directives? Lots of times it's difficult for us to accept, until we actually fall sick. What are your tricks?
So, good evening, one and all. I mean, it's a privilege to talk among, professionals who are involved with this. And when you have reached that stage where the living will matters to you and your families, I think the topic naturally comes up. I'm in my late 30s, and for the past decade, I've been practicing only these. To be very frank, I'm more into the community geriatrics, where the out of hospital services like the assisted living, skilled nursing facilities, the palliative care, home care. So that is the most part I deal with. So no, I'm more familiar with the 80 plus, 90 plus, and especially the NRI families who have their parents down here struggling to give the appropriate care and all that. So as you said, the living will conversation always doesn't begin in the first instance for a geriatrician. Okay, so it is for a role of a geriatrician is always longitudinal, because once a patient comes to a geriatrician, the stickability is more than any other physician, because we address their unaddressed problems. For example, nobody is going to ask an 80-year-old about a urine problem because they know that exists and we cannot cure it. The normal general physicians hesitate to ask about it. But when we try to ask about their balance issues, do they have the right appetite, whether how many times they pass urine at the night, that connection gets established. Now, when do we have these conversations about living will and all that? When the family has when the patient has repeated hospitalizations, they are getting frail day by day, and the family is struggling to take decisions outside the ICU. So that is when the conversation about the advanced health medical directive begins. Because we have seen, many of you said, advanced directive here is more less in paper, more in conversations. So people do convey us their will, but we don't document it. We don't want to write it down. Even the DNI, DNR, many hospitals don't have a standard form because it is still not legal to file it and keep it. So the problem, once the repeated hospitalization happens, we start the conversation with the help of principles of palliative care. Okay, yes, there is a background illness, the patient is frail, but when we start having conversations around that, I think Justice Kannan mentioned about the specifics in advanced care planning, where the whether you need to put a riles tube, whether you need to feed him, whether you need to do check his sodium at last stages. How do we deal with this? So internally, we as practicing geriatricians, we have come up with our own form on how to deal with this, step-by-step guidance for the families on how to fill that form, so that each conversation, just ask the right questions to them, and that prepares them for the next phase. Now it looks like a consent form. I can share my screen and I can not explicitly post in the content box like you have put. I can just share my screen and share the form here, where we take them across what would happen when the patient gets discharged, whether you want to go back to the hospital. First question, where if he deteriorates, whether you want to go back to the hospital, yes or no. If it is yes, at the hospital, what do you want? Whether you want an ICU. At the ICU, what do you want? Non-invasive or an invasive ventilation? So this gets asked, and moment we have this conversation, there is a question from the patient side: why are you asking this? And what is invasive? What is BiPAP? What is ventilator? And those questions come on. So at that time, we become patient's advocate and nobody else. It is not the family. It is not the intensivist. It is not the concerned specialist. It is not the oncologist or a pulmonologist. We become patient's advocate. So we talk about what is right for the patient, and what we give the scenarios. If this happens, yes, if you put him on a ventilator, it is going to take longer time. He will need a tracheostomy. Tracheostomy maintenance is painful, and it is going to take several weeks for recovery. And this is the cost you will be incurring. This is the manpower you need. This is how long you will have to stay out of work. So these are some specifics we give for the family, so that they are able to better able to take a call on what is needed, what is not needed. If the family is able to care for it, then that is okay. Why this is important is we have seen so many families take a decision and in impulsive decisions, and then regret it, going against that medical advice, just dropping them, removing, extubating them in the ambulance, just going home and passing away, or suffering with bed sores, pneumonias, aspirations forever. So to give that dignified death, we have to have these sensitive conversations. Yes, not everything is legal, and the legal route is very horrendous, right? You can transfer money, crores of money by an OTP. You can sign a term insurance by not visiting an office, but you cannot say that I want to die this way by without visiting your corporation or a magistrate. So that is a sorry state of affairs here, because the paperwork, I don't know signature, how it can be valid with this AI thing. AI can replicate my signature, your signature, everyone's signature, but you are still believing the signature is the one which is going to be. So I think uh, as the digital age is evolving, this paperwork should be done at home with appropriate counseling. Yes, with teleconsultation, many things are possible now. Yes, because these are necessary for 80 and 90-year-old. We are still struggling on, how to make this. Yes, there was Living Will Clinic in Mumbai, Bangalore. Yes, Chennai we will have. That was the internal decision we did have in my workplace. But whether will it solve the purpose? If the paperworks are heavy, nobody is going to go for it. Even for the organ donation, there is still struggle for the families on how to go about it, or where to call, when to call, the awareness about it. Especially again in a 80 or 90-year-old, they want to donate their eyes. But who will educate them about what is required, how to do it, what is a timeline for that? So there is a lot of awareness needs to be done, and there is a lot of expeditation by the enforcement agencies to expedite or ease the process. So that is very much needed. So if it is okay, can I share my screen once?
Yeah.
Yeah.
It's interesting you mentioned about the age, your difference of age between. So I think sometimes you might need to be in touch with the next of kin as well, who are more your age.
Yes, yes, yes. It's a more of a personal thing. Can you see my screen, sir?
Yes.
Yeah. So this is a form. This is just a letter from the representative of the family. I can just run you through this. So you can see that the family member signs on behalf of the patient, and they say that they have been informed by our team on the clinical condition. After that, the first question, transfer to tertiary hospital in case the clinical condition deteriorates, yes or no. If yes, as I said, intensive care, whether you need a non-invasive, whether you need an invasive. And if they put no to the answer question 1, at the facility-based care we give, at the facility, what sort of treatment do you need? Whether you need an oral antibiotic, whether you need an IV antibiotic, whether you need an oxygen, whether you need a feeding tube, whether you need lab investigations, whether you need IV fluid if oral intake is reduced, whether you need CPR at all. Now, if the question answer to the question 1 is no, CPR is a no. So, and we have just mentioned, I mean, this is not a legal document. I think justice won't get offended by me, because this is not a legal document. It is just an understanding between the family and the treating physician, we geriatricians. Since we deal with day in and day out with these with families dealing with frail elderly. So this is just how do I stop this screen?
Yeah.
Puneet, can I just butt in for a minute?
Yeah.
Thanks. One, Vasant, why do you say that the conversation should happen only after patient has gone to ICU a few times? If they are under your care from before, why not before? That's one.
See,
at registration, at registration itself.
I'll just finish my question, then I can take.
Please.
And the other thing is, like, why is it not the patient who's signing it? And if the patient has dementia or is unconscious, something that you leave. But why is your format directly seems to assume it is the family which should sign and not the patient? I mean, I'm just asking. I know you said it's not a legal paper, all that. But, that is my. What was your thought process? A, to have it signed by the relative instead of the patient, and B, why do you think 2-3 ICU visits are required before this conversation starts?
Yeah, so this is purely based out of the experience which we had faced. Okay, because the patients we see sometimes one moment they don't want hospital. I don't want hospital is the living will they want. How do we decide? A patient has a fall and is bleeding, might need suturing, might need some first aid at the hospital, but they don't want to do it. Now, this gives an advantage for neglect of that individual as well. Okay, a living will can needlessly see. We have seen families waiting for patients to die so that they can take possession of the property or whatsoever it may be. So now, for an able individual, when the completely treatable, reversible condition is there and they deny the hospitalization, now it should not become a neglect on our part. And especially in palliative care, for example, let me tell the palliative care. Yes, feeding. Someone said, yes, in a comatose patient, why do you feed? But in the principles of palliative care, the nutrition, hydration, pain and symptom management is the 4 pillars. Till the last moment, in the form you would have seen, we don't ask about questions about the feeding. We are not going to stop the feeding. If the rice tube is there, we are going to give. If there is an oral feed, we'll try till last moment. So that is the goal. So we cannot just stop the feeding just as we like. And for the first question he asked, why do you think about the repeat hospitalization is a marker. It is an indicative marker of the mortality marker, where more hospitalization leads to more frail status, and that is where we see the patients. So as I said, it is based on of what we kind of see as I personally see the patients. This document was decided. And when it comes to patient autonomy, yes, the patient can still sign these documents if the patient is mentally capable. Now, here, mental capacity assessment, who does it legally? Anybody knows who does mental capacity assessment legally? It's a government psychiatrist, unfortunately.
No, it's a simple thing. The person understands is all that we need to know.
Then
what it can be anyone, your son, yes, a daughter.
Patient, see, mental capacity, again, we were asked to be given by a government psychiatrist, mental capacity, because this was asked by a sub-register who wanted to, patient, there was some thumb impression needs to be done, and sub-register visited, and they were doubtful whether the patient was mentally capable, and they wanted a government psychiatrist to sign it. So
now you see, these are not normal requirements anywhere in the world. I think we have invented these requirements. However, there is no legal position in our country which mandates such a practice to assess mental capacity. It is given to the patient.
Correct.
In the 196th report of the Indian Law Commission, they don't recommend. They've gone into this question of assessing capacity. It is
Yeah.
by normal
That's all.
medical
But
process.
we can be sensible.
Yeah, it is a clinical judgment.
Yes.
You don't have to complicate. You are complicating your own specialty.
Yeah.
Now,
We can be
geriatric
sensible, like a
specialty,
lot of
you are
people
going to assess for every patient like this. Almost every other patient will require some form of treatment limitation in your case.
Yeah.
And this is not practical, and nor is it required. You are only shooting yourself in the foot by having these requirements,
No,
which
I'm
are not
just
mentioned
sharing
anywhere,
what we found
neither
out.
in world practice nor in our practice. So we are only inventing something.
Yeah, I mean,
To
unfortunately,
complicate
there are
matters.
so many things we need to balance out.
Yeah,
So
yeah.
I think those checks and practices, we will smoothen them out. Like for instance, Will's one of my classmates, one of my oldest classmates actually, she came to me after the crash in Ahmedabad and wanted her will. So I said, why me? We're meeting after some 40 years. And she said, no, I wanted a doctor and a lawyer. So I realized the sense of that. So I think if we are sensible about it, nobody's going to have a problem. So I think some in the hospital, the whole thing about the legal framework is, I think, to make sure that there's no, as our country is famous for organ sort of exploitation, so that this could be a potential space for conflict. So I think those checks and balances are there, but I think we have to sort of surmount them early. So I think Vidya's question was absolutely valid about why not do it. The first time the geriatrics,
Yes.
I remember one. I did a theater workshop in Kerala Museum where there were six of us. I was the oldest, the only geriatric person, and two young. They were who eventually are now Malayalam superstars. The first exercise they gave us was, you are dead. I think they wanted to dissociate you from the. So they said, you are dead. Somebody is reading your obituary. You have to act out the part of that person who's doing the obituary. What are they going to say? And I've gone through this so many times. I said, one of my kids is going to say it. They're going to say that there's going to be a Hasya Kavi Sammelan or a comedy show, because I want people remembering me laughing, not crying. So these kids couldn't, figure out. One of them said, my dog. So I think as a young person, you might be better if these kind of directives are actually at the very first, when you're doing your first assessment. I think if it's done as a matter, that checklist was fantastic. I think, in fact, I'll borrow that from you, because if you do it at the first assessment itself, the family knows and they have time to discuss it while the guy is at his first illness itself. So I think we need to relook at some of those. And I think with that we should, Dr. Vasant has clearly shown us what valuable insights from the Indian
Puneet,
context.
I must come in a little bit here, because you mentioned organ transplantation. Now, this is a bogey in the public mind, that we are pushing
Agreed. We just
people
come to that.
towards
Let's finish
treatment withdrawal
let's
only
finish
to
the first
remove their
round.
organs. That is not feasible in this country, because deceased organ donation is only in the context of brain death, and there are clear protocols how that is achieved. Okay, so
I mean,
in this treatment withdrawal, it doesn't need to come in. This fear is again a bogey.
No, I completely agree with you.
There
I've
is
been on the
no risk of organs being taken from the patient
No, but
without
it's the fear is there.
anybody knowing.
Dr. Bhatti, we have to address the fears. Sanjay Nagral,
Yeah.
one of our prominent medical ethicists, had raised this point that we said brain death only when organ donation is there. Why don't we talk about brain death in other patients?
That's a different. I agree with
So
you.
Just think of the situation where the person says, okay, now he's not fit to donate. Okay, now we are not declaring brain death. How awkward it is. So there are interlinked, and I think we have to go beyond that and understand that we
Yes.
have to instill the faith in the public as well.
Yes.
So we have
No,
to
I
balance it out, and I think it'll only come
No,
with
that's why I want to
gradual.
clearly state there
Yeah.
is no confusion
No, I
with
get the legal
organ
point, but
stealing here.
we have to appear to be correct as well. So I think so with that,
Puneet, I think Raja wants to say something.
I just wanted to say that I think with the poor integration of palliative care in geriatrics and chronic condition is where a good communication, when the patient and you have a great rapport, the patient realizes where you're coming from, the fact that you care for the patient. These are very crucial points. And I have moved from Bombay to Chennai, and I see that this city really lacks integration in non-oncology palliative care. It doesn't exist. So dementia patient is referred only when he's lost all his marbles, which is not the time. As a neurologist, pulmonologist, this is going to happen. So I think integration of palliative care, involvement with robust, good communications, which most of us doctors need to train to talk well. And your 90-year-old, your 80-year-old has become 80 and 90 over those many years. So it is the onus of the physician who's looking after him to pick up that conversation and start those conversations when he's able to decide what he wants to do in an emergency. I think it's extremely important to respect autonomy, whether you're 80, 90, or 100. But you need to start those conversations early. It cannot be one coffee table conversation.
No, I think that's absolutely true, and I think we also have a shortage of both palliative care physicians as well as geriatricians. So with that, we got Dr. Vasant's view on the Indian context. Dr. Ganesh Ram, you practice geriatric medicine in the UK, where advanced care planning has been part of the system much longer. I think we've learned a lot from there. All our initial geriatric people came from, were trained there. What can we learn from this experience? Can you share how it's integrated? What lessons from the UK system might be applicable to the Indian healthcare context?
Okay, first of all, thanks for inviting me. I hope you can hear me.
Ganesh, if you can just tilt your camera a little so that we can see your whole face.
Yes, yeah, I can't see.
Perfect. Yeah.
Is that okay?
Yes.
Okay. Yeah, thanks for inviting me. Yeah, I think I was listening to everything. But most of the legal status and all the requirements are more or less the same in the UK as well. There probably is slightly more uptake of this advanced care planning, because when we practice, we probably see about 5 to 10% of the patients that are coming into hospital who are critically ill have some form of advance directive. Either they have given a clear verdict to the family as to what the requirements are if they had lost capacity, or many of them carry a documentation explaining what their actual refusal to treatment is for certain conditions and what they prefer as their quality of life. So again, we see a few advanced directives, and you don't need to go completely legal. You can use, there are various websites, like one of them being Compassion in Dying, which is an organization which provide individuals who have got mental capacity to clearly describe what and how they value their life and their quality of life. If they meet with any medical condition, not specifically one or the other, but if they come with a medical condition, and if the treating physician can't meet what their expectations of quality of life after treatment, then they have the ability to refuse treatment. Now, if this document is filled when they had the full mental capacity, and as long as it's witnessed by another person that person has signed, then that becomes a valid legal document for the doctor to act. And so if, for example, in that circumstances, you decide that we will not be offering this treatment because this patient or that particular person did not want the treatment to be continued, then it is legally valid. So you will not be taken to court for not providing the treatment as long as you have the advance directive. So I think that's the advantage of having advance directive. Even though it's widely available, as I say, it's only very small percentage of the population, and the individuals take up this and have a valid document. I have a valid document being a geriatrician, and I have my own advance directive as to what my care should be if I went into hospital. But it also requests you to disclose this information to your close family members, who you have told and what you have exactly documented, and give a copy to your primary care physician. And if you can carry, then you can carry the paper or leave it into your medical document. I think one interesting thing that I listened is this digital documentation, which I seem to be more available in India. I have not come across this digital documentation, people carrying this information to themselves. So it is slightly more advanced, and so it's still the onus is on the individual to have this advanced directive. There have been some directives for within UK, but it didn't actually successfully happen, is that they would ask any doctor to discuss anybody entering into some sort of care setting, like a residential home or a nursing home, to have a conversation about their future and their care plan. That is what was recommended to lots of physicians. But first of all, people do not have the time. I don't think people sometimes are willing to hold those conversations at any time in that stage of life. Not necessarily when they come to end of life, at any stage. Some people do not want to have this conversation. But for those people, the recommendation is you have the conversation as early as possible to have a clear documentation as to what they value as the quality of life and what treatment they would want. Now, I think we had the brief discussion about capacity of assessment and who should and what the validity. In UK point of view, any individual can assess capacity of the other person. That includes a nurse looking after a patient on the ward. If they refuse to have a particular intervention on the ward, it is a nurse's duty to assess whether that individual have got the capacity to refuse. They have the capacity to refuse, the nurse can't give the treatment because it will be classed as an assault. And so, at least in the UK, the capacity assessment falls on to every single clinician who are practicing, be it nurse or a doctor or any other person. And the one last thing, when I was interested to look at the geriatric clinic in Chennai's, the documentation we have we call it slightly differently, called treatment escalation plan discussion with patients rather than advanced care planning. I think all those details about whether you want to be treated for an infection or whether you want to be intubated, we use them as a treatment escalation planning with the patient if they had the capacity. I think it's slightly more advanced in UK, but again, the number of people taking up those advantages are still probably 5 to 10% of the population. It's not widely seen. If I go to a ward in an average month, I would come across at least 5 or 6 of this, which is definitely more than what people, my colleagues who are practicing in India tells me that they see as much. I'll stop there if there's anything else that's specifically asked. Okay.
No, thank you so much. I think we've sort of heard the diverse perspectives, legal, ethical, clinical, across different settings, even countries. I can see we have several questions from the audience. Let's address some of these now. And meanwhile, I'd like to have the panel think on the poser. What do you see as the single biggest barrier to wider adoption of living wills in India? And what's sort of one practical step we can take to make it more popular, to make it more effective and prevent any malpractice? In your closing comments also after the audience participation as well. Is there something specific anybody wants to raise based on these questions? Otherwise, we'll open out to the audience.
Before the questions, it's just that about the capacity is something which I thought, like what Ganesham said, there is no particular requirement at all in law here as to who shall judge on the capacity. It's just anybody. But then there is a case, Sucheta versus the Chandigarh administration, which is a different thing. It's about a mentally retarded person wanting to retain the fetus. When asked by a doctor before the judgment, she said, what is happening to you? Do you know what's happening? The patient said, there is a doll within me. What do you intend doing? I'll play with the doll. The two judges thought it was not sufficient at all. She has not understood what a pregnancy meant and therefore will terminate. The Supreme Court reversed the decision. They were talking about good enough for a mentally retarded person to think that there is a doll is good, that there is someone to play with, and that's going to be a live child. So therefore, what is the nature of instrument, what is the nature of consent in a particular situation is what we are talking about. So therefore, it can be a lower standard of understanding, and that's still okay. So for a mentally ill person who can't take a decision is just out of question. But then a fickle-minded person who is fed up with the multiple illnesses over a period of time and say, no, I don't want to be resuscitated at the time. That's fair enough, because there are other circumstances which is compelling her to do is not the question at all. That a person is stable, understands what he's doing. Whatever is the circumstance which is forcing him is a different thing. But we evoke all those emotive questions. Is the poverty which is causing him to do that? Is it good enough a reason? These are things which we are bringing. But as far as the law is concerned, a person who is 18, who knows what he's doing, is a person who is competent. That's what it is.
No, I think you raise a very, very important, pertinent point, especially given that the TPA payment ends at a certain time, and then those decisions come. A lot of times we take those questions at that time. So and I think there are a lot of questions based on that as well. So whether we should be addressing them, only when the patient deteriorates, that was Vidya's original question as well. So we have a lot of questions.
Supendra has his hand up. Do you like to?
Right.
Is it okay to ask him to speak?
Yeah, go ahead. So I was in fact going to start with his first question only. Are there hospital ethic committees that assist individual physicians in making these difficult decisions? That was, I just looked at, just going to start with her question only. Do you want to add to that, Subendra?
Yeah, I think, listening to, first of all, thank you for this amazing panel. I think this discussion was well worth it any part of the world. I feel very honored to listen to so many people speaking across generations, across specialties. If I could just mention this with my background. I trained in India in CMC Vellore and JIPMA Pondicherry, then went to England. So I'm familiar with what I learned. And I learned a lot in England, the conversations, the level of discussions. And then when I came to the US, this was New York in the middle of the AIDS epidemic. What I found was shocking practices regarding end-of-life care and things like that, which was it was a wake-up call for me that things are done so differently in the West. In India, we did at that time in the 1970s and 1980s, we had very little, but I learned so much in the UK, and over the years in the US, we've worked on this, learned a lot of things. The ethics committee in the hospital I've found to be very helpful. Not every physician has the expertise to have these difficult conversations. So what we try to do is put together a group of physicians and others, non-physicians as well, who could contribute in a difficult discussion. And for individual physicians, this was really a great source of, I would say, not only hope, but also happiness to some extent in dealing with these very difficult cases. The medical legal situation in the US is obviously very bad. And so, this comes to you as a source of support. And Justice Kannan, one of the things that stuck with me with what you mentioned was that it comes as a relief to the family as well. When you have a group of, people assisting in the decision making, and the family feels okay, a lot of effort has been put into the decision making process. So I think that's where the ethics committee really plays a major role. Can I go on to
Yeah, I think we have you asked that question, one of your first questions. We do have ethics committees which are distinct from the research ethics committee and distinct from the mortality morbidity meeting. I can see our own mortality head also here. It's not the same because it's a resource for both those groups, for all the physicians, as you said. So I think it's important that we have them in all our hospitals.
Excellent.
And I think if we don't have them, this is a good forum that we can put together. Just like the National Cancer Grid, we want there to be, tumor boards. So those people who don't have access to tumor boards, smaller nursing homes and all that, we are providing a forum where they can actually address them nationally by some experts in that particular cancer. So I think this is a good forum that we should start off a offline ethics committee where they can, send all the documents. So it's easy for those the physicians, and it looks non-partisan for the patients as well, because they have somebody they can discuss it. And that's one thing we don't have is, patient sort of advocates. Patient advocacy is not there in India. So that's another topic I think, Vidya, we need to address at one of the future forums. Every time we get a good topic for the next time. Right.
Dr. Piyush Sani wanted to say something, I think.
Go ahead. Piyush. Go ahead, Piyush. Till he switches his mic on, can I?
Sorry. So I just wanted to say that, a lot of us as physicians stop thinking. And we often our reactions are, very different from what they should be. As a physician, I agree we are supposed to, keep a person alive. But sometimes we've got to realize the futility of life. A patient with an ovarian cancer, with a pathological fracture, undergoes a surgery, has a cardiac arrest, you put her on a ventilator. And the family says, we didn't want you to put her on the ventilator. You say, no, how can I do that? So we gave it to you in writing. No, but the patient didn't give it to us in writing. Now, you see, this is the kind of approach that we have. And I agree with Dr. Mani that, we often shoot ourselves on our feet and say, this is not practical. We should do it. I'm going to get into trouble because of this. Even when the legal framework is there for us to do what is right. And we are scared of doing the right thing. I think we've got to stop being scared of doing the right thing. Thank you.
No, I think that's absolutely correct, because we're not trained for that. We are trained to it's easier to put the patient on ventilator, not to have those discussions. I think Dr. Harikrishnan and others have actually mentioned about importance of communication, which is not taught formally to us. And I think that's single most important thing through medical humanities, through various other things, films and all that. We need to show the importance of that. And I think what Piyush says is absolutely spot on. We're not trained. We don't have that expertise. And, we fail at it miserably. And we try to, go on the science side of it without actually looking at the back end. Subhendra has your hand up again. Yeah, go ahead.
Sorry to bring up, I just wanted to make a couple of more points. Dr. Iyer mentioned something which is very important. In these decision-making process, when you start late in the hospital, it's often too late. So what you need to do is plan upstream. In the US, what we've done is we've split up these components into what's called life care planning. So for the chronic illnesses, like the ones you mentioned, Dr. Iyer, the process starts, in the clinics, in the primary care doctors' offices and places like that, because that is the time when the patient can really participate. And as the disease process is progress, so there are every specialty has their own diagnosis from which they focus. Then again, Puneet, something you mentioned, we don't have enough geriatricians and specialists. I was also thrilled to see a geriatrician on this call. Primary palliative care, which is a more basic level of palliative care, we feel can be done pretty much by any physician in the hospital. I'm talking about in the hospital setting. It can be done outside as well. So those basic discussions, a surgeon admitting a patient to the hospital where you think there may be issues, can have that conversation and then do a screening so that the more difficult discussions and the next level of care could be done by a geriatrician, palliative care specialists, and others who we have less of. So we have life care planning, primary palliative care, and specialty palliative care. in a way that helps streamline this entire process. And the third thing I just wanted to mention, and this is to Vidya, Puneet, and some of the others, in last November, when I presented on geriatric surgery, senior surgical care, I made a plea for a multidisciplinary team to take care of these patients ideally. You have actually assembled a multidisciplinary team right now in this panel. And this is an example of what can be done, even if it is done remotely, when you don't have all the resources at your place, which help. And Puneet, especially the kind of patient you mentioned, I think it makes a big difference if you bring a team in like this. Of course, having a justice on board is an added bonus. Thank you.
Thank you. Should we proceed with some of the other questions? I think Radha Pan has said signatures vary grossly with age. How can we show it's the patient's signature? I think as many of the other people have commented, it need not be, we need to document with the family and you have to make everybody aware of
Not
it.
without reason that you have witnesses. Witnesses
Exactly.
are supposed to attest to that fact.
Exactly.
So there can even be a mark. It need not be a signature. It can just be a pen mark. And another person saying this mark was put by him. This is recognized by law as sufficient. A person does not need to sign. He can take the pen, put it on the paper and give it back to the person who was holding the pen. Then he can say this mark was put by him. That is good enough, equivalent to your signature is what the courts have said.
And I think there is sensibility, like Piyush said, that we have to be sensible about it. I think there is a sensibility to it, which we need to be, sort of common sense approach to it. Venkatesh has said that if the patient is not compos mentis and is moribund, and there's disagreement between family members, one wants to escalate care, the other doesn't want to, what are the necessary steps the practitioner should do in order to expedite a decision and protect oneself against frivolous court cases? I don't think court cases come about by if there are, between the three. Invariably, we've been asked to, for our opinion, and most people stick to that. We don't have to push it down their throat. But I think if we explain both sides of the picture, and address the one who's we feel is needs more education, most of them do come around. Most of the litigations has happened where they've actually been completely in agreement, and it's subsequently some other issue which comes up. So I don't think we worry as doctors, like you said, we worry a lot about this particular aspect. I'm not sure it's true if our communication skills are good enough, and I think that's the bottom line we need to sort of push. Dr. Rajan wants to say something.
I also think that we doctors are not trained at all about legal aspects.
Absolutely.
So the fear of the unknown, we don't know. We think everything is, oh God, I'm going to be sued. But if you talk properly, if you communicate with empathy, compassion at the right time to the right people, document it, I don't think we are going to be, sued for everything. So point here is we are also not aware of the law. We think everything is going to be, questioned and in the court of law. We also need to get aware of the law. We also need to do our due diligence about what we are talking, whom we are talking to, document everything, be clear about what has been told, what has been understood, and what is the final plan. I think it's very important. I think all of you will agree that most of the lawsuits that happen is because of poor communication or lack of it. So I think that is the key. And medical training in palliative care, I think the curriculum, not having palliative care to produce compassionate, empathetic doctors is another big lacuna in India. We need to start 18-year-olds from talking politely, or bedside manners, body language, communication skills. You can't expect a 30-year-old to come out of a medical school and be compassionate and kind, because in India it is grilled very differently. You are the one to save lives, and you're the blessing to mankind. While it's not true, you can do nothing without patience.
And how well you can answer multiple choice is actually your degree of this, which is crazy. We don't look at the passion, the compassion, the background behind. I think your point is absolutely valid.
Puneet, Dr. Mani wanted to say something. Dr. Mani,
Sir, we have over legalized everything. All decisions are not legal; they are ethical and clinical. Yes. Now, more than legal knowledge, we don't have ethical knowledge. We don't know our own duties of care. It includes beneficence, non-maleficence. It includes compassionate communication. It is not something for which you have to find time. It is a part of your job.
Yeah.
So I think we have to be better grounded in ethics and simple duties of care.
Yeah.
Better, more. That's not just to do a procedure without thinking. It's not to give a medicine without discussing the consequences. You see,
And invited some doctors who have done a
appropriateness. It's a
law
judging
degree
of
as well.
appropriateness of care.
Yeah, none of them turned up. I mean, I'm also doing currently a course with the National Law School, Bangalore, on medical law and ethics. I think it's the fear we need to get rid of. Like Dr. Mani said absolutely correctly, I think it's we need to address our own fears. So we need counseling more than the worry that something's going to happen to us. I had touchwood, I haven't had a single court case, and I think we've had very, very complicated cases. But it's the communication which is clue, which is everybody said there in their comments, and that's a leitmotif I can see in the discussion as well.
Dr. Rahul Pandit wanted to say something.
Yes, Dr. Rahul. Yeah, sorry.
Yeah, no, sorry. Partly answered by Mani sir. That's why I went quiet. So it's about communication, communication, communication. The scenario which you mentioned about family having two fractions, wanting to do something, somebody not wanting to do something, is an everyday scenario we come across, sir. Every single day, I at least have one or two decisions with the family. And if you spend time with them, the problem is doctors are not spending time with the families. That's the only problem. If you sit with them in a quiet room, have a chat, and say, what are your concerns? You will actually find out that most of them want to be they're looking at a similar kind of a care plan. It's just that their understanding was not clear. Once the understanding is clear, they come around. Very few, 1 in 100, may have a disagreement after discussion and communication. I think that's the one which is going to be odd one out. You will have to just wait for them to accept, give them more time, and see how it goes.
Dr. Tara has mentioned that poverty is a reason to withdraw support, and sometimes we send a patient against discharge against medical advice or lama dama. So it was common and moribund. Is that Dr. Mani has very rightfully said that it's not a sort of death in dignity. So I think that's one place. But when we have this ethics, finance, private setting, we can't dump somebody in a public setting. So there are a lot of ethical issues here. So that's why I think the preponing those discussions is probably extremely crucial before they reach the brink of poverty, and the rest of the family doesn't have to die without in indignity as well. So are there any other questions which are important in a
Anyone who would like to speak, you can just
raise your hand,
or unmute yourself or turn on your camera.
There are many new people.
Chat box is flooded, so we may miss something in the process. So yes, Colonel Harikrishnan.
Well, firstly, thanks. I'm so grateful to most people who have endorsed my views. I've been keeping on talking about it, about communication being the basis of every problem we face in situations like this. Now, my wife is attending this meeting with me because we are in our 70s and we would very much like to be informed about, advanced directive and things like that. She has got a question which I'm finding it very difficult to answer. Maybe the panelists need to look at it even if they don't want to answer. And that is, how come nobody is talking about the potential possibility of greed on the part of private sector hospitals in sustaining life? Somebody needs to take up this question and at least try and answer.
That's absolutely spot on. I've tried to avoid being in a pure private setup for that exact reason, and I think you're absolutely spot on. We heard, when I was in Delhi as a student, we heard when the first private hospitals came up, we heard that they're keeping patients alive because of, I'm pretty sure some of it is all fiction, but that fear will not go away, and there is a potential, way to keep it. So I think that's where we need some patient advocates in each of these hospitals. I'm not sure how many have them, but Dr. Mani, would you like to? I mean, I'm sure you must be facing that.
See, unfortunately, all the Supreme Court judgments emphasize the misuse of withdrawal, okay, while ignoring the elephant in the room. There is a huge misuse of interventions, life support, in the name of medicine. I mean, actually, we are being patient advocates by promoting end-of-life care. See, at least 30% of patients in the ICUs don't need any of these interventions. This is based on a European survey. It must be even more in India. In Europe, it's all state-owned care. Here, it's all mostly privatized, 80% of care. So this is all driven by monetary consideration, selfish consideration. So we ought to be guarding against this misuse. The other misuse is minuscule and imaginary.
And
I
some of
think
it is fed by the patients as well.
no, they
We
said,
have money. We
yeah,
have
no, they
money.
said, yeah,
What is the best you can do?
yeah, the
So we tell them
physicians,
what's the best we can do rather than what is the right thing to do.
yes,
I think Dr.
exactly.
Hari is
Now, what's the
absolute, and
best
both of
thing
you
to
are saying.
do is to provide dignity to the care and compassion to the care. Now, here, the courts are not asking how many people are being unnecessarily being ventilated in the ICUs. You see, that's why you can't take an extreme view of preservation of life at all costs. It's not at the cost of the living, it's not at the cost of the patient's own interest. So this is something which needs more discussion, I think.
Dr.
And
Mani,
the potential is
not only in the private, even in the public. When I was in AIMS Rishikesh, I was looking after emergency for a short while, and I had this. This is immediately just before COVID, the 2 months before COVID, and we had a shortage of ventilators. So a terminally ill patient was linked to a ventilator. Another one coming in status asthmatic actually had the potential to die. So somebody salvageable could die. So I think these are what you raise is absolutely spot on. And Justice Karan wanted to make a point. I think in between.
No, see, there's one thing about private hospitals. There is a flip side to it. What I saw when I was in Chandigarh as a judge. At that time, the director was asking me to address the people on developing a protocol for withdrawal life support. His point was people suspect your decision to stop any medication, further medication, because you want to create a bed for another person. There is always a pressure on beds, and a more resourceful person stays on, less resourceful gets jettisoned immediately. So therefore, you need a clear understanding about what you need to do. It's just not the private hospitals. Government hospital, the difficulty is that you withdraw even earlier than what is necessary. That is a suspicion. So therefore, it's just that I wanted to say that even in government hospital, there are other issues which keep coming about and that they want to address it. It's just not merely the private.
Absolutely true. I think if we have specific criteria within each ICUs and protocols as to which is the first next patient which is going to be shifted out. I think most ICUs have a rough protocol, but if it's written, I think the suspicion on the part of the patients also goes away. So I think that's a very good clue Justice Karan has given us that we should try and have that as transparent as possible.
Glad this was brought up because there is no hiding the fact that even in Chennai, I would say we see. I was talking about the patients. Why we talk of, because I personally see patients coming from other private hospitals into our setting. At that time, it feels unreal. The amount of the duration of the ICU and all that feels unreal, and it is mostly the guilt trip. The NRIs, they want to do, they cannot be present here. They want to do something for their family, and they think the ICU is the best way. So that time, the problem, and most often the intensivists are young, and most of the hospitals are manned by postgraduates doing anesthesia, doing critical care, and it is a fair truth. And when a family member asks them to empathize, when they want the family member to put in their shoes and decide, I don't think they have the experience to decide on behalf of a elderly gentleman or their father or mother. So that is where the problem lies.
That brings us to training, because I think the curriculum needs the training, and secondly, the awareness in the society. As a society, we need to train people to ask for comfort care. Like they say, a no means no. I don't want that chemotherapy. I don't want the ICU, which is where the importance of advanced medical directive is. If people come and say, I don't want this, we can't and we shouldn't be pushing them to. So we need a huge paradigm shift in the way we talk to society, make people aware of this so that they start asking. Because I see this difference, having come from another metro, that the listed hospitals behave very differently from trust hospitals. So the whole point here is the person shouldn't be suffering for that. We need to make our citizens much more aware of their rights and say, I don't want this means it has to be respected. And for the person to make that decision, he needs to be informed by a good, sensible, compassionate doctor so that he can make an informed consent. And he's not just, because he's suffering the pain or because he's not able to spend the money, he's saying no. So I think that is very, very crucial.
Yeah, I think we need more education to the MBBS students on all this rather than on how many branches of middle meningeal artery or the scalenus anticus. That's not going to Dr. Rajni Surendra Bhatt and Archana Kaul, you've unmasked yourself. Do you want to ask a question or?
Just a comment. I'm an
Sir,
interventional
it's a little
pulmonologist.
bit. Sorry.
Yeah, sorry. So I'm an interventional pulmonologist and palliative medicine physician based out of Bangalore. And it's been fabulous listening to this wonderful panel. So many important points brought out. I'd like to just comment on two things. One is what Dr. Rajam said about training and communication. All of those points that were made, extremely important. And this is something we try to bring out in our everyday practice when we are telling our junior colleagues, associate consultants, when I walk into a room and I have a conversation with a patient with interstitial lung disease who's not a candidate for a transplant about what to do when they come in for an exacerbation, and I have a goals of care conversation with the patient and the family member, I'm usually doing it for the second or third time after previous conversations in the clinic. And when I walk out, I will ask my junior associates, what communication technique did I use? Did I use an ask, tell, ask technique? Did I use the hope and worry technique? So just like when I'm doing an EBIS TBNA, am I doing a jabbing technique or a poking technique? There's techniques to communication. We have literature from Indian critical care which talks about the lack of understanding that this is a procedure that is learnable. And that I think is great, that's what we need to work towards. The second is, as physicians who offer organ supportive measures, just like a surgeon says this patient is inoperable. Is there truly an inoperable patient? Everyone's operable. It's just what is the consequence of the operation.
Even
So is
stuck to
this
the
patient
operating table.
ventilable, hemodialysable? I should be able to say this patient is not hemodialysable for good quality of life. This is
No, I think
physician autonomy.
you raise a very important point because for the first time I read there was these guidelines on pancreatic cysts, the IPMNs, which for the last 20 years they've been changed a lot of times, the Sendai guidelines and all that. Last year I saw the Kyoto guidelines, the first time in medical guidelines I found follow these patients till they are till they are able. If you're not going to do anything, what's the point of following them up with repeated things? So we know at a lot of times that we have the opportunity, but like Piyush said, we are too scared to raise those questions. I think we have to be sensible about it. I haven't actually we are most scared. I haven't come across a patient who's not willing to talk about it, even from a rural setting, from a low socioeconomic. People say they're not educated, they won't understand. I said, you give me a chance, and they're so sensible. I think we just need to improve our communication skills. I think this seems to
Very
be
true.
the
If I
more
may,
motive.
there is actually data. Dr. Naveen Salins has published data about the willingness of rural women diagnosed with cancer to talk about advanced care from Tata Memorial Hospital. And this is typically an older woman from a rural background without financial autonomy who is not going to be told about her illness. We are assuming our Indian population, citizens, patients are not as intellectually aware as they are. They are. They just need us to step up to the plate.
Absolutely.
Also, I think a lived experience speaks volumes. What they go through and what their body tells them is something we underestimate. They know what they're going through. A lived experience is so crucial, we just completely dismiss it because we've read it in the books, so we know more. But I really think we need to appreciate and give more time, give more credibility to our Indian patients. It's irrespective of education or money.
Dr. Archana, would you like to come in now?
No, I think that's.
Archana Kaul, you had your camera on for a while.
No, I think that was my mistake.
So Ramanan, on to you.
Yeah, I think coming from the Indian background, India has always celebrated death for ages together. If the Western community is able to convince patients to have a dignified death, in India, the scenario must be really very, very easy. Only thing is that we as doctors are either afraid to take the conversation or don't have time to do the conversation is what I understand. Otherwise, almost all patients understand and they kind of agree to whatever we say also. As Dr. Mani said very clearly, are we doing the right thing for that patient is when we start checking that honestly, I think the decision making will be very easily on that aspect.
I think we're coming to the end of our time. Is there other questions? Otherwise, everybody can give their closing statements, starting with Justice Kannan.
Yeah, I would think we need some practices to be placed. I'll make only 2 points. One is just like an insurance agent, for a life insurance agent, when he is canvassing for a policy or for underwriting, he doesn't talk about death necessarily. It doesn't really rattle you, does he? He's saying during your lifetime, for your lifetime, this is what is the insured amount. It's the same way. The hospitals must see at the time when you're admitting a person, because there are many instances where a person walks into hospital, he goes out dead. You never know what can take. So therefore, to ask, is there an advance directive? Is there something which you can give to us? Is something where a person comes there, where a person is not in a comatose stage, where he's coming to ask that and keep it in a record is a good way of doing it. That's one. Two is something of what I wrote about. We need a strong lobbying for a change of what is necessary. How is this document made? When can it be modified? What is the thinking period before when it can modify? There kind of a digital registry which must be there, which is possible. A national digital portal ought to be there available. It ought to be linked with your Aadhaar or something. I'm not giving any novel idea. This is something which I wrote about in the Hindu about 3 months back. I will still reiterate that. And these things get to happen only if there are institutional clamor for such a change. Otherwise, our own parliamentarians will not even know that something like this happens. And there are quite influential people there in the panel of who I see. You need to be pushing for something which makes it easy for us to secure this as a practice which we should make possible easily. And that's all. These are 2 points which I thought I would make a mention about.
No, I think extremely, extremely important. Dr. Mani, you're muted.
See, I think all I have to say is that we have enough in law now to practice ethically. Okay, there are many elements which are still not in place, but we must follow the spirit of the law, not just the letter of the law. The letter of the law is dependent upon the powers that be, the bureaucracy, who have to put in place the entire system. But spirit of the law is it has to be a collegiate decision, a treatment limiting decision. It's not an individual decision. It has to be done with a group of physicians and the family. So it's a shared decision. That's what the court is saying. And then we must have championed the cause on behalf of the patients. Treat with care, with appropriateness, with a sense of balance. And there is no imperative to just pile on expensive and extraordinary care at all. So this we must bring to the bedside. This concept we must bring to the bedside. Then rest will happen. The systems will come in place. In the Transplantation of Human Organs Act came in 1994. It was 1998 before all this was took. The systems were in place for it to happen. So I hope this will happen in the course of next few years.
I think we're still in evolution, absolutely. Dr. Pandit?
Sir, I would like to only say that medicine is an art. There are no straight lines or columns like engineers or geometrical designs. So in the art, you will probably need to spend a lot of time with your patients, talk to them, understand them, and like an artist, create something which will actually suit to your particular patient. That's why medicine is called as an art. It's not an engineering or a mathematical science where you can have 1 + 1 = 2 all the time. You will have different patients, you will have different families, you will have different wishes. Same person would have, a patient with a similar problem would have expressed a completely different wish before, and vice versa. Another one would have wanted to live as long as I can be supported with. And I think we need to understand that we need to hear their voices. We need to actually spend time with them. And that's where it is lacking. If we just spend time with our patients and their families, none of this discussion would be required online, sir. It will all happen at the bedside in a very, very meaningful way, can be documented, and it would actually just make sure that none of the legal complications ever arise. They only come because we don't spend time with them. We don't show empathy. We don't show that we are concerning for them.
Very, very true. I think we don't look at the social history to see what would be the most suited for that patient. I think we are taught that, but we actually don't implement that. We've got that list of present illness, past illness, all that kind of mugged up stuff. But the social background check, I think that's one thing we lack. And again, a humanized medical humanities approach is, I think, very crucial. Dr. Vasant, the young geriatrician.
Yeah, two things. See, one is digitization. The ABA ID is coming up. I think living will should be at the top. Just like we write allergies in the case sheet, living will, what you want, what kind of treatment you want, should be at the top of those digital record. Second thing is, I think integration of palliative care into specialty and super specialty training. I know that a lot of us talk about undergraduate training, but I feel once it is most important for the super specialist and the specialist where the in palliative care should be part of the subject, part of the assessment when they pass out. Thank you.
Extremely valid. Dr. Ganesh.
I think listening to, I think the more important thing would be communication. Also, making this advanced directive a public awareness is for people to understand that they can do this in advance. Would be useful. I know it may address only a part of the population who are educated, but it doesn't mean whether it's educated or not. People need to be aware that they need to take hold of their own health and their life for future. How it can be done, I suggest that it can happen, but how it is going to be done is going to be quite hard, especially in India, I suspect.
Yeah, where we are used to being the my bap, you only decide for us. I think very, very crucial what you said. We need to do that. And for once, it's a pleasure for me to invite Vidya and Patta to give their last comments rather than the other way around.
Yes, Rajam, Puneet.
Right.
Dr. Rajam, your closing comments, please.
Yes.
So I think, like everybody emphasized, training is crucial. Educating and awareness in the society is crucial. And I really cannot emphasize more on integrating palliative care into every specialty. Every specialist and every physician needs to know when to wear the palliative care hat, when to stop escalating treatment, and when to talk with compassion and empathy to patients and family. It is very, very crucial to make our society aware. And I think that's going to make a big difference when people are aware and they come to doctors saying, I would want palliative, I would want comfort care, or I don't want a particular kind of treatment.
Radhakrishna?
What an amazing evening that was. And Puneet, you did a wonderful job. And it's all high intellectual stuff that's going on. See, I remember when I was an intern, we were caring for a 40-year-old man who came with upper GI bleed. Some of the surgeons couldn't fix the problem and put on a ventilator. Madam Kangle, the chief of anesthesia mentor of Vidya, came and said, have you stopped the bleeder, caught the bleeder? He said, no. Then why are you wasting oxygen? I mean, that really, and only now I understood what exactly it means. I mean, it's a sad thing, like as somebody says, the NCCN guidelines about advanced cancer doesn't mention any of these. We only talk about, that chemo, this chemo, that, that, and knowing bloody well that, this many of them are not going to work. As you rightly say, Puneet, this should start from an early age where we should, more than being taught how many branches middle meningeal has, these things should be taught. And again, as Vasant really emphasizes, that it should be taught specialty, super specialty. We never, as a clinician dealing with advanced cancer, we never think of those areas, the ethical areas at all. It's a wonderful discussion and all. I mean, I think these videos should be seen by every medical person in the country and every corporate hospital, as a matter of fact. And as I rightly say, that there should be an ethics committee to deal with these areas, not just about research and publications. Wonderful evening. And as somebody said, that the right way to start the new year with this discussion. We hope to see more of these seniors coming in with more topics. Thank you so much.
Unfortunately, we had a lot of MBBS students also online. I was hoping some of them will ask questions, but at least they've got it. And I'm planning to show Whose Life Is It Anyway as part of the film club next time, in conjunction with this
Perfect.
Vidya, your last closing.
So actually, I didn't realize
Tables are
that
turned.
Pongal was falling on 15th. I thought it's 14th, and I went ahead and planned because we already took a 2-week break for Christmas and New Year. And once I decided the topic, immediately everybody accepted. And then Radhakrishna said, "You're going to do something on Pongal Day." And believe it or not, today at the end of 1 hour and 50 minutes, we have more audience than we normally have, sometimes even for at the peak.
The highest
that
ever,
shows
highest
that,
ever.
yeah. So Shashi, you wanted to say something?
Ma'am, I'm sorry, I joined the meeting late. I'm from Dean Foundation in Chennai. I'm a volunteer with them and I've just been trained by the Indian Association of Palliative Care. I was just wondering, would this recording be available? Because I seem to have missed the bulk of it.
Yes, yes.
Whom did you get the link from?
From my director, Mrs. Deepa Muttaya, the chairman.
Okay.
We are from Dean Foundation in Chennai. We are palliative care, home care people.
Okay. So, Basant, was it you who shared it with them, or whatever? I mean, I'm glad to know that the the link is reaching people. None of us know.
I had to go out
I will
on
just,
an emergency.
I will just.
It's available. It'll be available. It'll be available.
No, but how will it reach her is my point. So let me just type an email ID here.
Okay.
And you can send your details, and I will make sure that you get the recording.
All right. Thank you so much. It seems such an interesting topic.
I think it's time we have an Insta page, Pata, and where we can put it so that people can actually get the link for the thing, or once you have your website ready. Because I think some of these are very, very important topics which all of us need to revisit and see what
Puneet,
Puneet, this is one of the sessions for which I had demands about recording in advance. The minute we shared the poster,
so did I. Yeah.
People were either traveling or they were going to be in some other meeting. And normally I get these queries for the recording after the session. This is the first time I had so many requests after seeing this esteemed panel and the topic that, will it be recorded? Can I get a copy? And of course, I'm very happy, Radhakrishna and I are happy to see that the reach of marvelous medicine has gone so wide that many of these people, we don't even know where they got the link from. So that's why I wanted to know, because my broadcast list people will know the link, have the link and recording. So Radhakrishna, can you just update Puneet about our plans for how to take marvelous medicine forward?
Because marvelous medicine website is half ready, Puneet. I think, I'm sure in another fortnight it will be ready and fully functional. But then, of course, that putting it in a public space is a bit of a worry. Any Zoom link, because we've had experience of Zoom bombing and all that.
Yeah. Not Zoom, but the recording. I think like my daughter's a lawyer. All her friends wanted the recording also.
Definitely. Recording will be there on YouTube, definitely. Then we think we'll put it on the website as well as Insta. We'll do that. The process is on.
It's such a crucial topic, and even just catching the tail end of it is so interesting. Absolutely. And as a social worker, I'm really, really interested to know what I've missed. And
just let me say, isn't this this obviously is a paid for Zoom workplace. It is not a free one because we have gone way past the 40-minute limit. So therefore, your recording should be automatically coming to you, Dr. Vidya and Dr.
No. I have all the recordings. Yes,
he does.
So it should be quite easy for you to.
No, they're doing it. They're doing it all ones available.
Sir, the issue is, of course, we do so many other things other than marvelous medicine. In addition to that, we have a lot of non-academic conversations in the beginning. So we need to edit all that. There's a process of editing, and we have an editorial team, and they do it. And of course, as I'm more lethargic than anybody else, and we don't do it on time, I think, and we'll keep doing it.
So the Zoom recording needs to be converted, and that takes some time. Of course, some people have suggested we go live on YouTube so that we don't need to upload, but
you can't edit it
we
later.
will assure you from now on, we have a team. Before it was just Radhakrishna and me, no one else. And now we actually have a team working to get the website and other things ready. And so this uploading of recordings also will happen faster. And hopefully in the next, by February, we should be able to share publicly the details about our web page and how to link faster with people. And then we are also trying today's conversation. I don't know how many, maybe next time we should do a poll of the age because invariably our audience is 40 plus, 50 plus. So we are desperately trying to get the younger people involved in this. If they didn't come, they have missed, listening to so many stalwarts, and also a younger person with whom they can relate well.
Yes.
So that is going to be our endeavor, how to take these topics. And long discussions are not the young people's forte. They want to see everything within few seconds or few minutes. So we are working on that as well. So we will be reaching out to all of you to help us to engage with younger doctors and trainees, and because it's not enough if just a few of us 60 plus sit and discuss this topic. So thank you once again, everybody, for sparing your time on a holiday. And it was wonderful, such an interactive session. And we hope to have all the panelists back for part 2. Maybe Dr. Mani can lead with, we can have a session dedicated entirely to end-of-life care, where the rest of the panel can also chip in. Thank you once again. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Good night. Bye-bye.
Good night. Thank you, ma'am. Thank you, ma'am.